Start recording. All right. Can you guys see my PowerPoint? Yes. Okay, I was like, you don't see? Okay, perfect. All right, perfect. So this is obviously our, well, I'm Professor Bugg-Cutler for those of you who don't know. And this is our exam number 3 review. We are almost done. Almost done. All right. Here we go. So these are all of the chapters. Looks like a lot. That are on the exam. Is it really a lot? Not really, because think about it, some of them really like coincide. We know about anger, aggression, and violence. We know about delirium and dementia, somatic symptoms, all the things. So this is really a challenging exam, but easier than before. All right, the first chapter or concept, bipolar disorder. Off the cuff, just tell me about it. Tell me about mania. What is mania? What kind of behaviors would you see?
Impulsivity.
Impulsivity, absolutely.
Mm.
What else? Be like a lack of sleep.
No eating, self-care.
No eating, no self-care, basically lack of all things except for what they're hyper-focused on. Remember, individuals who have bipolar disorder typically start lots of projects. Like Ellen said, they become very impulsive, compulsive. The individual may never, do something, like maybe never drink alcohol or something like that. And then when they go through a manic episode, they drink alcohol. So basically, like you both said, doing things to an extreme or lack of, like Angela said, not take care of themselves, things like that. What about hypomania? If mania is like literally this up here excitement, basically they need to rest, like rest and reset, right? What about hypomania? Just a lessened form, right? So it's
Yeah,
so high.
just dragging around.
Yeah, so you're just like, okay, so I'm excited, but I'm not up here, I'm down here, but still in its mania, lesser symptoms. Questions about that? All right. What do you think, like bullet point number 2, what do you think the most important thing other than safety is about bipolar disorder? Because so we know they're impulsive, we know they can be compulsive, erratic sometimes. So the main thing besides safety would be boundaries. Every patient that comes into our unit has to have boundaries. Boundaries have to be enforced, limits have to be set, expectations have to be set. What happens if someone knows an expectation, knows a limit, and breaks the limit? What should occur?
We have to redirect them and reinforce them.
Yes, absolutely. Redirect, reinforce, and just say, hey, like this is what's expected. This is, that kind of thing. But there should be a consequence. Not like, seclusion or restraint, but, like Angela said, redirect, reorient, like, hey, like this is what's expected. So limit setting structure is absolutely important. So limit setting, making sure they know the expectations. Again, they may have altered state of mind. So setting expectations, setting limits, providing structure, most important after safety, okay? Do you think individuals who have diagnosed bipolar disorder are at increased risk for suicide?
Yes.
Do you think individuals with bipolar disorder have an increased risk, for substance use or alcohol use? What's the rationale? That you're both right. What's the rationale?
Because they're not thinking safety. They're not, they're not thinking safe. They're not, yeah.
They're not thinking in their like quote unquote normal frame of mind without the symptoms, right? Yes. So alcohol use, substance use, again, like going back to the whole mania, doing things that they normally probably wouldn't do, being sexually promiscuous, stepping outside the marriage, blowing, lots of money, those kinds of things. I had a patient whose husband almost left her. We had to provide a lot of education. She newly diagnosed with bipolar disorder, and she almost ran out all of their savings account, and it was a hefty amount. I think she bought like 2 cars. And then the individuals who sold all those cars at the lot, they really probably took advantage of her because they should have known she may not have been in her best state. But yes, so um, we always want to make sure that we are setting limits, setting boundaries, providing structure, okay, and all obviously safety. If Are we supposed to ask individuals who have bipolar disorder if they are having thoughts of self harm?
Yes.
Yes, we ask every patient that, right? That's part of safety. Good job. When we think about bipolar disorder, this type of speech patterns resemble those of schizophrenia, right? Some of those same ones. Clang associations, circumstantial speech, and tangential speech. What is the main difference between circumstantial speech and tangential speech? There's only one difference.
Circumstantial, they make their point, and tangential, they don't.
Absolutely. With circumstantial speech, they eventually do get to the point. They add a lot of unnecessary details, but they do get to the point. Tangential, they go on a tangent. Like Ellen said, they do not stop. They do not remember what the question you asked it was, but they will just talk. Okay. What about clang associations? Kind of a giveaway with the word clang.
Like rhyming.
Like what? Rhyming, exactly, rhyming words. Noodle, poodle, ding dong, tick tock, click clack, things like that. Again, they have uh, altered neurotransmitters increase and decrease in their brain. So all of that altered speech, the symptoms, everything is because of that alteration. Okay. Questions about that? What about interventions as a nurse that we can do if a patient is maybe when we say aggressive, like you can just see they're getting little tensions building up. What kinds of things around the unit, like little activities, do you think that you think you could employ to ensure that pent up energy is released? Because that's what it really is. They have a lot of energy and excitability, right? So if we can get them to do something physical, that's probably away from other people, that might calm them down. Does that make sense? So give me an example of something that we may do like on the unit. I used to work fresh out of school, geriatric psychiatry. Um, I found out really quickly that my elderly patients love to fold laundry. So I gave them a quote unquote job. You know, if they're up late, they can't sleep, I'm not going to give them any medication yet to zonk them out. So just give them a task. So if we know an individual with bipolar disorder is highly excitable, sometimes impulsive, sometimes aggressive, sometimes they have very irrational thought processes, what can we do? One, we do need to get them away from people, right? Keep them safe though. So what are some physical things that we can do?
Like
Have their
coloring.
coloring, yes. So basically, you're telling me, and I hear you, and I agree, that solitary activities that have some kind of physical relief to them, right? So that
Mhm.
again, good job. So that release of all that excitability with bipolar disorder is they're focusing, right? They're coloring. Them, what is that called? The mandalas? Is that what they're called? Those coloring books are like very, very like extensive mandalas. I don't know. I'll have to Google that in a second or something. But yes, coloring takes time. Sweeping the floor. It's not like they're like there to do chores, quote unquote, but that's an activity that they might find interesting at the time, right? Folding laundry, um, asking them to, straighten books or something like that. But again, solitary activities that do provide a release of energy. That makes sense. So they
Mm.
all that out in a very productive, calm, manageable way. Very good. Very good. What types of medications do we give bipolar disorder or get individuals about bipolar disorder?
Is that the lithium
Yep,
medication?
lithium. So mood stabilizer, right? Lithium is the only mood stabilizer. It's a salt. Now on your drug sheet, you'll see, I think I put like mood stabilizers and anticonvulsants. Yes, we can use anticonvulsants like Depakine, Depakote, Lamictal, Tegretol to treat bipolar disorder too. But the main drug that you're going to give is that mood stabilizer, which is lithium. Okay. Sometimes we can use antipsychotic medications, but truly it's going to be lithium, the mood stabilizer. Okay. Lithium is a salt. Where sodium goes, water follows. So, what education do we need to provide to them about intake of water or hydration, period?
To drink their water, drink release. Make sure they got their fluid intakes.
Absolutely. So, should I go if I drink let's say I have this diagnosis, and every day, before my diagnosis, every day I drink 32 ounces of water. I know that sounds like a low amount, just making the numbers. I drink 32 ounces of water, and then you are now giving me lithium, it's a salt, you're providing education, and you say, what? If I said something like, I used to drink 32 ounces of water, and now I'm on this medication, it makes me so thirsty, and so I am now drinking 75 ounces of water a day, what would be your next uh, thought or action statement to them?
So you have been drinking 32 ounces and you're thirsty now.
I'm on lithium. Lithium's a salt. So we're sodium
Okay.
water follow. So it's going to make me
Thirsty and it's gonna make you urinate a lot, right? Because almost dehydrated. Right.
absolutely. And we like you hit it on the head. Good job.
So
We
you want to increase your fluid intake to like, is it to decrease or increase?
maintain.
Okay, okay.
Good job. Good job. And I like the way you said, do we want to or not? Because that was really good critical thinking skill. Because you
Mhm.
did, you put it to the test. Like, let me see. Lithium is a salt. I
Mhm.
know where sodium goes, water
Mhm.
follows. Like you said, dehydration, uh,
Mhm.
hypernatremia for drink too
Right.
much. So good job. Yes, where sodium goes, water follows. So we need to maintain that fluid intake and water. So maintain salt, maintain fluid. Good job. There should be no true changes unless they weren't drinking like any water like at all. They're just drinking like caffeine. But yes, they need to be drinking the same amount of water. Try to do the same amount of salt intake. If anything, now again, maintain is what you want to do. But if let's say we're talking about like diet wise, like heart healthy, low cholesterol, it would be like low sodium, right?
Low sodium diet or whatever, right? Like just decrease like the sodium in your food and okay.
So that's sweet. Good job. Good job. Okay, so if we're going to give lithium, lithium has what side effects? The major
Mhm.
one is toxicity, right?
Mhm.
The toxicity. Um, how do we know if someone who is on lithium is experiencing any kind of side effect of toxicity?
Check their lithium level.
Yeah, yeah. Okay, so we draw lithium level. Good job. And what do you know what the normal lithium level is?
0.6 to 1.5.
Good job. Yeah, yeah. I've got zero point 0.4 to 1.5, but zero point 0.6 that's okay too, because again, that's a therapeutic level, right? So when we do give a patient lithium, it's a salt. We maintain salt intake. We maintain water intake. Okay. We know they can have different types of speech patterns, clang, where they rhyme, circumstantial, where they go add necessary details, but they get to the point. They have tangential speech at times where they just go on a tangent and never get to the point. Okay. We have to focus on boundary setting, limit setting, and providing structure. Remember, outside the hospital is chaos. Their emotions, their mood, everything is chaotic as well. So we, as the nurse, are the tool as well as the milieu to keep things structured. Okay. What is the rationale behind giving medications? Why questions? Why do we give meds? To target symptoms, right?
Yeah.
So what What is lithium targeting? What behaviors do we see with bipolar disorder? So what makes the medication?
It's going to stabilize their mood.
So exactly like you said, so impulsivity, compulsivity, aggression, anger, those kinds of things. Good job. Good job. Again, go back to side effects. Again, toxicity with lithium. Signs and symptoms, lethargy, vomiting, tremors, diarrhea. What else? Maybe it. Fever, weakness, those kinds of things. Okay. What questions there? Questions. That's it. Are we good there? Bipolar disorder? All right, depression. Depression is our next concept. Give me the definition of depression. What is your definition of depression?
When you don't have the energy to do things that you normally would.
Absolutely. And what's that called when you lose the motivation to do things that you once enjoyed?
Anhedonia.
Absolutely. Great job, anhedonia. And we'll get to that later too. Yes, anhedonia. Um, what else? Depression symptoms. Symptoms of depression. We know these: hopelessness, helplessness, risk for suicide, risk or other self-harm. Like you said, anhedonia, we can do the A's, like anhedonia, avolition. So loss of pleasure, anhedonia, loss of motivation would be avolition. What do you think is the most important thing with depression from a nursing implication standpoint? Something
So
very
that's about any suicidal thoughts or
clearly.
harm.
Yes, they are at a increased risk for self-harm, aka sorry, triggering suicide. That's because again, the neurotransmitters that are at play. Which ones are those? Think about your classes of I almost gave it away. First of all, let me back up. What medication class do we give for depression?
Antidepressant.
I was about to say that, but that was like, I said like in a really, really weird way. Yes, antidepressants. Yes. So we use antidepressants to treat depression symptoms. I mean, that was funny.
The SSR ones, right? Or
Yeah, so SSRIs, SNRI. I'm sorry, y'all. I'm like,
it's okay.
how did I ask that question? Like, that was just, you're like, and yes. So we have, sorry, it's gonna be a good video to watch. So yes, the neurotransmitters that are at play, like you said, SSRIs, SNRIs, tricyclics, and MAOIs. So the neurotransmitters that are at play with depression are serotonin and norepinephrine. What does SSRI stand for? Selective serotonin reuptake inhibitor. So that's serotonin. We are increasing our serotonin. Serotonin is responsible for our mood, sex, overall well-being, or even our satisfaction with being full after we eat. Okay, so serotonin. Also, SNRIs, serotonin norepinephrine reuptake inhibitor. So there is more, we are allowing for more serotonin and more norepinephrine to be present. And both of those neurotransmitters work with, again, concentration, alertness, overall mood, sex, well-being, satisfaction with enough food. Does that make sense? So serotonin, norepinephrine. Side effect. Again, there are different classes of antidepressants. SSRIs, gold standard. That's the one we always go to first. We always go to first. Sorry. Sorry, 1 second, okay? I'm gonna pause 1 second. All right, so yes, we're talking about antidepressants.
For 1 minute to the serotonin, you said those are the uptake of serotonins, right? The SSRIs, right? And
Reuptake inhibitors. Yeah.
inhibitors.
So
Okay.
good job, and that's a good question to go back to as well. So if we say SSRI and SNRI, tricyclics, MAOIs, kind of
Mhm.
like flippantly, like you said, we just, oh, but what does that really mean? Like you said,
Okay.
SSRI, selective serotonin reuptake inhibitor. So if you're
Okay.
inhibiting the reuptake, that means there's more. And if there's
Okay.
more serotonin, like mood, sex, well-being, happiness with food, SNRI, serotonin and norepinephrine reuptake inhibitor. So they're increasing norepinephrine and serotonin as well. So there's more. Norepinephrine is responsible for like fight or flight. So your alertness, your concentration, your memory, right? So when those antidepressants, those two classes, SSRIs and SNRIs, are given, they're increasing serotonin and norepinephrine. How long does it typically take for an antidepressant to actually get into our blood system, do all the things, increase these neurotransmitters, and actually we start to see actual outside progress for the patients? How long?
About
For
4 to 6 weeks.
weeks.
4 to 6 weeks. Some say 4 to 6 weeks, around that range, but it would never be less than 4 weeks, right? You're not going to do immediate change. I wish it were like that. We'd have maybe less self harm, maybe. But absolutely yes. So 4 to 6 weeks for all of these antidepressant, every class to work. Now, will a patient potentially tell you that they are starting to feel better after they start taking medications for like a week or two or something? Sure, right? Again, we have to think about pharmacokinetics, dynamics, all the things. So how it affects every single literal body. So usually 4 to 6 weeks, things like that. First line treatment would be SSRIs. Okay. When we think about mm,
Then,
y'all, I apologize. My daughter's friend is staying the night, and they're like, "Where'd you put the ice cream cones?" I'm like, "Away from y'all, so y'all wouldn't eat them." I swear. So sorry. But yes, SSRIs, gold standard. Um, give me two, give me three SSRIs medications, just three. Three antidepressants that are SSRIs. Always remember, like, um,
fluoxetine, that's
yep,
Prozac. Mm-hmm.
absolutely. I always remember that one. I always remember fluoxetine, aka Prozac, um,
Lexapro, but I don't know how to pronounce like the other name of it.
escitalopram. Yeah. And like you said, does it matter if you know how to pronounce it? Not right now, right? It just matters if you see it. You're like, oh, yep, I know that's Lexapro. Good job. Uh,
And Zoloft.
and what'd you say?
Zoloft.
Yes, actually, yes, Zoloft, sertraline. Good job. Those are actually all three really, really good drugs. Add in citalopram as well. Celexa, just a cool thing. Celexa and Lexapro are monomers of each other. They have one little thing different, and that's where we got escitalopram from. So Celexa, Lexapro, Prozac, um, sertraline, or Zoloft, like you said. If we're talking about side effects of antidepressants, SSRIs. The normal nausea, vomiting, diarrhea that always, like they say with every single medicine, right? Um, but in particular with fluoxetine, aka Prozac, what can occur? What is that one thing?
The Cottonmouth.
Hot mouth. So if I tell you I'm thirsty, you know I'm on fluoxetine, and you know that, or in general, you know that that causes dry mouth, all the things. What kind of education can you provide to me?
Stay,
Is it? Oh, I'm sorry. Go ahead.
stay hydrated.
Stay hydrated. Again, consistent amount. Sugarless candies, like things to suck on, right? Like sugarless gum, sugar candies, things like that, hard candies. Kind of keep their mouth wet. Headache, dizziness, with fluoxetine, hepatic impairment for sure. Okay. Um, SNRIs, kind of same thing. Select Cymbalta Effexor Pristique. Not too many side effects there other than like agitation, restlessness, things like that. When we go to tricyclics, we really don't want to be in that drug class because it has a lot of side effects, sedation, sexual dysfunction, visual disturbances. They can actually hallucinate, abnormal heart rhythms, all those kinds of things. Anticholinergic effects with tricyclics as well. Okay, so everything dries up, kind of like Angela said earlier, I think. The last antidepressant class is MAOIs. MAOIs, monoamine oxidase inhibitors. Okay. Monoamine oxidase breaks down tyramine, that's the chemical present in aged cheeses, wines, pickled foods, smoked foods, things like that. So if I put a patient on an MAOI, what teaching do I have to provide to them?
How to avoid those foods that high.
Absolutely. Avoiding those foods, pickled, aged, smoked. Somehow avocados got on this list, and I'm really trying to like figure out
I
how.
still can't understand that one.
Like, and I recently just like today years old, like not today, but like literally recently found out, and I'm like, how? I don't know. We'll have to figure it out, Angel. We'll have to figure it out next time class. But the MIIs like Nardale, Marplan, Parnate, we don't want to be here because they cause hypertensive crisis. Big medical emergency, okay? You always, if somebody walks up to you in the unit, you always, after they say, like, I have a headache, what's the first nursing action?
Check their blood pressure.
Their blood pressure. And then I know, like, in class or other times, people have said, like, oh, the pain, when did it start? All that's good too. But we need to see if they're on an MAOI, we need to really make sure that they're not starting to experience hypertensive crisis. Good job. So always obtain vital signs. That's your starting point right there. That will tell you a lot of things. So then you can automatically rule out too, like, oh, it's not that. Like, it might just be a regular headache or something like that. Okay, good job. Um, Therapeutic communication is very important. Each of you on the spot, give me an example of something therapeutic that you can say to someone. It can be really simple. What can you say to a patient who's experiencing hopelessness and helplessness?
Tell me more about how you're feeling.
Tell me more about how you're feeling. That's a very open-ended question. And again, think about it. Sometimes people don't have support systems.
Mm-hmm.
And when you don't have support systems, that one nurse who asked that one question, tell me more. How are you feeling? Sounds like you are experiencing some severe symptoms. I'd like to know more. Do we understand? Do we know what they're going through? No.
Mm-hmm.
Even if, again, even as nurses, if we're like hopeless, helpless, all the things, but we're showing up to work and trying to make our money and things like that, we never know how anybody else's body brain is working. So while we can empathize and say, like, in our brains, like, yeah, I know how that can be, we never ever want to imply that we know how the patient feels, right? We never want to take that away from them because that's like actually not validating anything. You're basically just saying, like, oh, it kind of happens to everybody, and you don't want to ever do that, right? So again, tell me more. Give me another one.
Or ask them, do they have anyone to talk to? Or
Absolutely, yes, absolutely.
would like to talk to somebody. Yeah.
Yes. Ooh, that's a good one. Yeah. So again, back to support systems. That's a really big deal. Um, research actually shows if you have support, if you have a mental illness, any mental illness, and you actually have a support system, you're like 90 something percent more likely to be stable and at a similar or at a lesser baseline than you were before, which is really, really great news, right? But does everybody have social support? No. So that's where, again, like your question, Angela, is do you have a support system? Who can you count on? Who can, you call, things like that. They probably should be able to identify somebody. If they don't, then we really need to get them set up with therapy, things like that before they even leave our hospital. Okay. So again, depression, therapeutic communication is so imperative. We want to build rapport. We want to build trust. We want to validate. We never want to make them feel like they're a burden, those kinds of things, right? We always assess for suicide or thoughts of harm to someone else as well. Okay. Um, when we assess for depression, we can use certain tools, assessment tools. There's tons. I've just picked out a couple up here. The PHQ-9. I'm not too sure if you guys have heard of that one before. I think we briefly, I think I mentioned it on our voiceover PowerPoint from class that week. But the PHQ-9 is it's in the past 2 weeks, several times a day, like listen all those things, and you rate them, and you get a number, and that number will tell you what you should do. If it's over a certain number, that means they probably should be immediately hospitalized, taken to the ER or psych hospital. Okay. Um, the Beck Depression Inventory Scale literally is an inventory, very basic. It's an inventory of how depressed someone is. And that's really, really important. These are really important. So if we're talking about screening tools to kind of rule out or determine how severe someone's depression is, we always can use the PHQ-9, and we always can use the Beck Depression Inventory Scale. I like the Beck inventory scale better because it's just like legit. Do you have this, this, or this? PHQ-9, it gives it even seasoned mental health professionals like the question in the past 2 weeks, have you felt blank? Like less than half the time, more than time. I'm like, what exactly is more half the time? So for depression, if we're using assessment tools, I really like, although there's the PHQ-9, the Beck Depression Scale, there's tons of others, but these two are really important and good to know. And again, the Beck Depression Scale literally is just that, an inventory of all the symptoms that the individual's experiencing from the depression. Okay, so really, really important screening tool. Okay, we talked about pharmacology. We talked about the neurotransmitters were serotonin and norepinephrine. We talked about side effects the hypertensive crisis for MAOIs. We talked about anticholinergic effects with tricyclics, hepatic impairment, dry mouth, things like that with SSRIs. Questions there. And then obviously CBT. What does CBT stand for? The treatment of choice.
Cognitive behavioral therapy.
And what are we doing when we are having a patient treated with CBT? What are they doing actively with the therapist? So cognitive is thoughts. So
Changing their thought process of how.
absolutely, we are working to change their faulty, distorted beliefs, and basically figure out where they came from. Like, where did this sort of thought of no one loves you, you're not important, fill in the blank with depression, you're the only person that feels like this, to reality orienting with the therapist. Depending on the severity of the symptoms, it could be like kind of quicker, like 1 to 2 weeks, or it can be longer, long term. That's okay. Again, it keeps the individual cognitively thinking and aware of their faulty thought processes. Okay. Things to avoid if you're on an antidepressant or basically taking any medication. What kinds of things do we always like to say? You hear it on the commercials about every medication possible. What do we avoid?
Stopping abruptly for it. Don't stop taking them.
You said what?
Don't stop taking them abruptly.
Yeah, do not stop abruptly. If you're experiencing side effects, call in and let us know.
Alcohol.
Yeah, no.
Alcohol? Yeah,
Mm-hmm.
yeah, avoid alcohol. Alcohol can actually induce depression. Like alcohol can initiate depression. Or if you already have depressive symptoms and you drink alcohol, you now have what's called substance-induced depression as well, right? So we really, really want to make sure that we key in on education on side effects, education on what to do about alcohol, other drugs. Again, if we're given SSRIs, serotonin syndrome, too much serotonin can occur. So we're also asking about herbs like St. John's wort that is believed to increase serotonin. So if someone's taking that herb plus a antidepressant that increases serotonin, they can have serotonin syndrome. So we're always asking questions. What medications are you taking? Over the counter, prescribed, not prescribed, all the things. Avoiding alcohol, avoiding diverting the drug, avoiding skipping it or abruptly stopping it. Good job. Are we good there?
Mhm.
Tell me what anhedonia was again. Anhedonia.
Like a lack of energy.
Lack of any, like, so yeah, lack of pleasure. So I used to love doing ABC. Now the patient says, like, I don't even have the idea or thought process if you want to do that anymore. Anhedonia. Good job. And then avolition, again, we lost of like motivation. I don't even like want to do anything. Okay. We good there? All right. Anger, aggression, violence, and sexual assault. I'll just boldly say right here, just like trigger warning for this the whole slide when we talk about things like that. Anger. What? Well, actually, anger, aggression, violence, and maybe sexual assault too. What might be the greatest indicator for violence, anger, aggression, sexual assault?
Past history of violence.
Past history, yes. So again, remember it all starts at home. So if an individual, and I'm not saying everyone who has anger, aggression, violence, it starts at home, but that's the biggest predictor of future anger, aggression, violence, sexual assault, things like that, is past history. Either they've seen it, they've experienced it, or they've already done it, right? So the biggest indicator for future fill in the blank anger, aggression, violence, sexual assault is past anger, aggression, violence, and sexual assault. Job. Safety is always going to be important with all of these things, obviously. We'll start with anger first. Again, therapeutic communication, de escalation. We always want to try to talk the patient down. In fact, you should be, you will get to the point where you're such a prudent nurse who just automatically knows, like, oh, my patient is probably about to get keyed up. So you don't let them get to a point where they are keyed up. You start initially, hey, like they're walking, pacing the unit, like, cracking their knuckles, like they're like really upset. You can, if you've built rapport with them, you can catch up with them, say, hey, I'd like to talk to you for a second. You appear to be, stressed, or you appear to be fill in the blank. Would you like to talk about it? Tell me more. Things like that. Okay, we always want to try to de-escalate first. We never want to restrain, seclude, chemical restraint, like medication as well. We never want to automatically go to that. But we want to use our therapeutic communication skills to ensure that they know that they're safe, we're safe, everyone else in the unit is safe too. Okay. I'll leave the nursing diagnosis examples to you guys, I'm sure. Risk for violence, risk for other directed violence. Anger is actually a nursing diagnosis as well.
Mhm.
Interventions. Again, remember, we're dealing with individuals who have, excuse me, anger, aggression, violence, and again, sexual assault as well. So you always want to make sure that there are no power struggles. We're not going to go up against an angry patient. We're not going to go up against anything like that. We'll never quote unquote win, and it's not even about winning, but in their eyes, it might be. So again, stand your ground, know what's what, and then know when to seek help as well. Make sense? So basically, what we want to know with the patient who is angry, aggressive, becoming violent or things like that is what is going on. Not why are you acting this way. It's what is actually going on. Tell me how you're feeling. Tell me what is truly going on. I'd like to know more. Those kinds of therapeutic communication skills, okay? Again, we never jump to restraint and inclusion unless we absolutely have to. What's the difference between assertive and aggressive? If I'm assertive, what does that mean?
Right.
You putting yourself in a situation.
Yeah, like I am direct. I'm assertive. I am saying, hey, this is exam number 3.
Mhm.
If I'm aggressive, what does that mean? My behavior, my emotions, all things appear to an outsider like I am about to do some damage, right? Okay. So assertive, again, kind of like a sort of communication, like with Hildegard Peptide, or helping someone ask for what they need rather than get aggressive and just take it, right? We good there? Right. Sexual assault and rape, just trigger warning, again, safety and empathy. We never, ever, ever, ever leave a patient alone. If they've been assaulted, we never want to leave them alone. That's a big safety risk. Plus, I don't even want to think about this or have y'all think about it, but we're future nurses. Um, we're humans, how would you feel if this terrible event occurred and you were just left in the room by yourself with all those thoughts, feelings, emotions pent up? It's not probably a good idea. So we're always going to sit and stay with the patient, provide comfort. Remember, silence is okay too. Silence is okay. They don't have to be talking to us, but silence is okay. Right? Again, they could be at such a level of anxiety that they are panic. That's running around, not being able to do anything but like automatic behaviors. Um, Biggest risk there, obviously, is risk for injury. Okay. De-escalation, um, therapeutic communication. Again, always. We don't victim blame. It doesn't matter what they were wearing, what they were doing, what was implied. No means no, right? And we're not detectives. We are there to use ourselves as tools for therapeutic and holistic purposes. We're not detectives. What were you doing? What were you wearing? Were you drinking alcohol? That's none of our business in that kind of way. We just provide that safety, comfort as nurses, okay? Again, the sexual assault nurse examiners, that's a specialty, and that individual would be the one to do the DNA swabs. Remember, you as the RN can also do body mapping, where you are basically just showing like where bruises are or knots, any kind of imperfections with their skin or whatever that have likely have occurred from the assault. You want to make sure that if there's no sane nurse at your hospital or something like that, and then if you have the ability to do that, you always ask permission to take pictures. Always ask permission. You always ask permission if they want to do the DNA swab, all those things. So they don't have to have that. And we offer those prophylactic drugs, for like STDs and things like that, but we don't have to do this sane nurse thing. Some people do, some people don't. You just ask them. Okay, we good there? Any questions? Anything about anger, aggression, violence, or sexual assault that you feel like you are missing? What drugs can we give? If anger is a behavior, violence, aggression is behavior.
Antipsychotics.
Yeah, we can give antipsychotics or even mood stabilizers, right? Because they target that. Good job. Yes, antipsychotics are really good for that too. Any other questions? Good. I'm trying to think. Okay. All right. Somatic symptom disorders. Somatic means what? What's that like that weird chapter? I think it's like chapter 17 or something like that. Somatic. Somatic mean we are expressing a physical
Possible pain or fatigue or feeling or just
as a result of what? An
mm,
emotion. So something physical is being displayed rather than just really coming out and saying like I'm super super anxious right now
mm,
or fill in the blank. So somatic. Good job. What symptoms might you expect? Angela, I think you said it. Kind of more vague, common problems that we really can't quote unquote treat, right? So headaches, yes, we can give medications, but headaches, back pain,
fatigue, just feeling
fatigue,
tired or yeah.
yes, all those kinds of things right there. The biggest challenge is going to be ensuring that they don't like quote unquote like doctor shop, right? Because some people with somatic symptom disorders, they again they believe that something
Wrong with them. Yeah.
yeah, good job. And we don't want them to not get what they want from us, like the words we want to hear, like, yes, you have this. They don't. We run diagnostic testing, things like that. We don't run too many. We just do just enough to make sure that we have covered all the bases, things like that. Okay. So again, the biggest intervention would be to like maybe like once ask them literally, would you like to talk? What's going on? That's those kinds of things. Again, the biggest challenge is making sure that they don't quote unquote like doctor shop, things like that, or they continue to believe that they're ill, or they're going to become ill, illness, anxiety disorder, anxiety that you're going to become ill, things like that. We good there? Substance use disorders, airway, breathing, circulation. Always, always, always. Alcohol withdrawal symptoms, narcotic withdrawal symptoms. What are those? Alcohol withdrawal symptoms. Sorry,
Withdrawal, like tremors
tremors,
and seizures.
Nausea, vomiting.
nausea, vomiting, triggers. What'd you say, Ellen?
I said seizures.
Seizures. Okay, yeah, seizures. Good job. What about narcotic withdrawal? What does that look like? Narcotic withdrawal.
Respiratory depression.
Respiratory depression, absolutely. What else? And again, I like how you probably thought about like medications like Narcan or something like that. Yes, good job.
They may feel like their skin is crawling, bugs are on them or something. GI upset.
Absolutely. Good job. Good job. The nursing role is to what? Prevent things like injury, like
Safety.
yes, basically say like all the things to make sure they don't fall in the chair.
Mhm.
What do we really want them to do? Sleep, right?
Mhm.
And really sleep. There are protocols that we use, again, like assessment things, CWA for alcohol, things like that. That would give us a number to indicate if we need to provide medication to assist with their withdrawal symptoms, things like that. They'll usually, depending on their consumption and usage prior to admission, will typically get better with the withdrawal symptoms, 1 to 2 days. Sometimes it's like 5 days. But that's okay as long as the symptoms are decreasing over time, not increasing, obviously. The nursing role, again, like Angela said, safety. Ellen, looking for, assessing for tremors, seizures, symptoms, those kinds of things like that. Educating the patient too. If you throw up, or, vomit, let me see how much. Some individuals, I hate to say this, but it's true. Some individuals who have substance use disorders, they know this drill about withdrawal symptoms, and the medication that we typically give is a benzo, volume. And so when you're asking those questions, that's what, to see whether you're asking questions to them, like, are they trembling? Are they sweating? Nausea, vomiting, things like that. We can't see if they can say they're nauseous, yes. Have they vomited? We don't know. They can say they have. And it's like, we're giving them the benefit of the doubt, absolutely. We know that these symptoms do occur. But again, you want to also be very clear that if they don't need the medication to assist with withdrawal symptoms, then it's better not to give it. If they're saying they're throwing up and pooping like crazy, ask to see it, because you really might need to see it. Like, what are they throwing up? They're likely not going to be able to keep any food down. So is it just bile? Is it dry heaving? Is it really diarrhea? Is it, those kinds of things. So you might want to ask to see that. That's not the most important part, but yes, the medication that we give some individuals, obviously they're benzos. Some people like that, and so they'll say they're experiencing all these symptoms, so their score will be higher, so they can get the medication. But again, safety, non-judgmental, compassionate, empathetic care, as always. What medications do we do for overdoses?
Naloxone.
Okay.
Good job. Good job. What about medications for other addictive substances? What can we use? If somebody's like in a program, they're managing they're detox off the drug of choice, substance of choice, or whatever. What kind of medications can we give them? Opioid use. And I think you were saying like methadone.
Mm.
Academy. Ellen, what did you say?
I didn't say anything.
Okay, I thought you said something. Like,
You said if they're off the drugs or coming off the drug, what medication we can use, or just
yeah, so medications for overdoses. Again, like if you find somebody like knocked out on the floor, you believe
the
they're
Narcan can be used for the opioids.
absolutely. What about medications for other substances? Like, what can we give? So they're addicted to alcohol. We can give what? Antabuse, right?
Mm.
Antabuse.
Can you
And
give
what's
lorazepam?
you give what?
Can you give lorazepam for alcohol overdose?
You can. You can. Um, what about buprenorphine, naloxone, antabuse? Again, that medication will avert, like aversion therapy, basically what we're doing with alcohol. We give them this medication. So if they do drink, they become violently ill, just like they were being highly
Mm.
intoxicated. So they don't want to feel those symptoms again. Good job. Questions about substance use disorders. Focus on symptoms. Focus on again what you might see. Focus on type of treatment. And you know your nursing role. Safety, safety, safety. Good there? All right, therapeutic groups. What are the purposes of groups? To get individuals together to discuss a common thing.
Goal.
Yeah, exactly. A common thing. It could be, there are different types of groups. Like it says, humanism. That's literally just a group that you might be healthy, you go to just to like keep your spirits bright, keep your emotions and thought process, clear. Cognitive behavioral groups. In there, we are in a group setting learning how to manage our distorted thoughts and things. Psychoeducational group. That could be education on my diagnosis. We can have groups about like psychopharmacology, where we are providing that education about the types of drugs, classes, or things like that. Again, the nurse's role is always going to be the facilitator. Different types of groups require different types of leaders. Remember that. We don't really want to be laissez-faire. We're more of like a Democrat, or I guess, yeah, like more democratic, less like more like authoritative kind of thing. We want it to be open and everyone can make choices. That makes sense? Everybody should have a say. Everybody should get a turn. What might be challenges in a group? Challenging behaviors. What might interrupt a group?
Someone with like mania taking over the group.
Yeah, someone who literally may be, and they may not even know it. I've led groups before. You were expected to learn to do groups as a nurse on your unit. And I always loved like psychoeducation and behavioral therapy or cognitive behavioral therapy. But the biggest challenge for me would always be potential symptoms, like challenging behaviors. Like someone can go to a group maybe, but their impulsivity may make them want to blurt out answers or interrupt someone else or try to take control of the group. So very kind of like matter of fact, kind of like borderline personality disorder, like matter of fact, but with lots of empathy, like a thank you for, like thank you, but right now we're gonna let Ellen share. Thank you, but let's let Angela say something too. It's like you may have to go to that point where it's open for people to answer, like class here, or the exam review here, or if somebody's trying to overtake their group, maybe with impulsivity, you might start like, "Hey, Ellen, what do you think?" Or "Thank you so much" to the person who is, answering, but let's give somebody else a try. And it's okay to say that. Let's give somebody else a chance to answer that question because we do want to hear from other people. I've been in places like that where I'm just like, okay, am I going to get a say? I don't think so. But again, impulsivity, compulsivity, main thing is really interrupting, and you have to just reorient. We have to re-establish our group. What are we here for? We're here to do this. This is a challenging behavior. We can sometimes dismiss the patient out of group. Do we want to do that? Not really.
It's 1 o'clock.
So if they can get a quote unquote handle on their behaviors, and after we like kind of call them quote unquote out on it, that's probably best. What is the most important thing about group therapy? What does it do? It allows people to what?
Have a space to talk and
I am not
get
the only person
along.
who feels this way. I'm not the only person who has a diagnosis of feeling.
What's going on? Yeah.
Good job. Good job. What about reminiscence therapy? When you reminisce, what are you thinking about?
Something that has happened in the past or something you have experienced before.
And is it good or bad?
It
Good.
can be good or bad.
Typically, it's well, I
It's
guess
a good thing. Yeah.
it can be. So yes, I can actually situations pop in where it could be like reminiscing about something maybe during therapy where you like have
Oh,
to go back to that point. Good job, yeah. But like we're earlier, like I was randomly reminiscing about like the '90s. I was born in '89, and so like the '90s, like thinking about like all the things like Tamagotchi, like all the things we had. I'm like, oh, that was like those are so cool, like all the things. And now everything's coming back. That's reminiscence therapy, where we are literally in a circle. You can do it individually as well, but we're talking about therapeutic groups, so more than one person. You are allowing individuals to, in a group setting, talk about the things that have made them happy, good experiences that they have had. And then, like Angela said, if it was more of like a individual reminiscent therapy kind of situation with the therapist, um, they might have to reminisce back to an old memory or experience in order to actually get that out and process. Does that make sense?
hmm
Good job. Um, any questions here? So the nursing role is we basically facilitate. We determine what kind of group is needed based on the population there. Um, there's closed groups, open groups, mixed groups, things like that. Make sense? Okay. All right. Severe mental illness means what? SMI. It just specifies what? The chronicity of it, right? It's not going to go away. We can treat it. There's no cure. And again, most of the mental health diagnoses that we have discussed during these like almost 10 weeks, it's almost time to go, are SMI. If you were in my class, Angela, you saw the PowerPoint slide, but literally I was like, what do you think of when you hear severe mental illness? Like schizophrenia was like the first one. I'm like, absolutely. And then I was like, and what else? Bipolar disorder, depression, PTSD, panic disorder, personality disorders. Again, any diagnoses of a mental illness that like significantly impacts somebody's ability to function, do the things they need to do every day. That's typically an SMI. And again, most of the again disorders we've talked about are SMIs, like severe persistent mental illness. Again, depression, panic disorder, things with agoraphobia. Those are legit severe mental illnesses. They might not seem like severe when you think about like schizophrenia is over here, like depression's over here, like, no, they're both the same. Yeah. Again, they're biological in nature, so they have like that genetic predisposition kind of thing. But does it always have to be genetic predisposition? No. But more than likely, and like what you've seen across these weeks, more than likely there's always some little snippet of a genetic component, right? Good. The yellow box is really important because as a nurse, anywhere, any like again, anxiety, depression, those are SMIs, severe mental illness. So it doesn't matter if you want to be a psych nurse or whatever. Individuals who are diagnosed with depression, schizophrenia, schizoaffective disorder, personality disorders, all the things are more likely to do all of these things here. Be victims of crime, have untreated illnesses, medical insurance, medical illnesses as well, like comorbidities, experience homelessness, be incarcerated, unemployed, live in poverty, engage in substance misuse. Those things are really important. Again, people who have a diagnosis of any severe persistent mental illness have issues with daily living activities, okay? They're likely unable to function in a work setting. Relationships are likely impaired. Think about personality disorders, things like that. Their ability to socialize, think about depression, PTSD, coping, communication, and task completion, they're all skewed, right? So that yellow box is really important. Individuals with SMI are more likely to blank. Again, we know some more than others, like research based, we know, like schizophrenia has a lot more like the psychosis and things like that. So, like, drug use might be higher here than in like over here. But again, they're all SMIs, severe mental illnesses. And again, they struggle with activities of daily living, including coping, communication, social interaction, relationships, all the things. Okay. But they often do, like the third bullet said, experience homelessness, be incarcerated, or have any like run-ins with the law, become unemployed, live in poverty, and engage in substance misuse. And again, is it their quote unquote fault? No.
No.
Again, it goes back to home being brought up, and it goes back to support systems. So if I have a diagnosis of depression, or I'll say if I have a diagnosis of schizophrenia, and I don't have a support system, I'm more likely to, again, experience homelessness, run in with the law, and not be able to hold down a job because of my symptoms, things like that. But if I have a diagnosis of schizophrenia, I have a support system, I'm on medication, I'm taking it, I'm doing all the things, interventions, then I'm at a decreased risk, but that risk is still there if I not adhere. Does that make sense? Questions there? Basically, SMI, primary biological or genetic in nature, doesn't go away. And then again, there's all of them basically. Bipolar disorder too, I think I said that. All right, the A's, talking about older adults. Complications, comorbidities, right? So it's not just their mental health, it's their physical health as well, right? Those are complications for older adults. When we think about medication implications, farm versus non-farm, what do we do, Angela, with medications? You're in my class. What do? We start.
Start low, go slow. Start.
Yeah, you said it right the first time. Yeah, start low, go slow. And that's with everybody, but because we're every patient, because we're talking about older adults, we always start with the lowest dose possible. And then we can always go up if we need to. But we're trying to remember we give medication to treat or target symptoms. So good job, yes. So again, medical implications, start low and go slow. If somebody's child is taking a medication that's 10 milligrams, they're like, wait, mom now has to take this medication too. Why is she taking 2 milligrams? Well, one, implications, and two, she might not need that much. So start low, go slow, and always think about the kinetics of the drug. How are they excreted? How are they absorbed? How do they move in the body? Especially how are they secreted? Again, back to that. Metabolize, liver, kidneys, things like that, or because of their older age. Not everybody is not healthy, obviously, but because of their older age, they are at an increased risk for more medical comorbidities, things like that. So we always have to make sure that we're doing a very brief, like, rule out any kind of psych disorder before we start with our plethora of things too. So back to medication. So we start low, go slow, always monitor for symptoms, be cognizant of how the drug is absorbed, distributed, excreted, or metabolized, excreted, things like that. If they have impaired kidney function and the drug they're given affects kidney function, then that really not doing a good job. Toxicity could occur very quickly. So non-farm is where I like to typically go first. What's the number one thing that you'll always hear your doctor say when you are like literally just like your annual checkup? And they're like, well, are you blank 3 times a day for a minimum of 30 minutes? What am I talking about? Exercise. Exercise. So again, and exercising doesn't absolutely mean like getting on the treadmill and running or, hiking like, miles and things. It's just really like, again, they're older adults, so stretching, just anything to increase mobility or keep that strength training in there. Again, we want the older adult to be as independent as possible for as long as possible. Okay. So again, pharmacology, start low, go slow. And then non-form could be what? Let's say they're in pain. What can we use instead of pain medication? We can give something like Cymbalta. That's not Cymbalta, excuse me. Gabapentin, really low dose because it can knock them out. But non-form, what can we use? We can get it over the counter now. About pain. Talked about it in
A
class.
lot like Tylenols or something, or
The I'm trying not to give it away. It's an
okay,
acronym.
let's ask the question again.
So, older adults, if they complain about pain, we don't always have to do form. We don't have to give them a drug,
Right.
right? We can encourage non-form things like stretching or
Exercise or rubbing creams or yeah.
so on that rub on the cream rubbing cream thing. What else non-form? Is a particular unit.
A heating pad or
Tin, tinge unit.
oh yeah.
Thank you. I was just like, how can I make this make sense? I was like about to say like it's an acronym like CBT, but but no. So
And
yes,
we talked about that in class the other day.
yeah, and I'm your teacher. No, I'm just kidding. But yes. Again, y'all have 8,000 things going on. So yes, a tinge unit. Uh,
Hmm.
it sends like the electrical impulses to target those areas of pain. So those are really good for elderly adults who, again, we don't want to just fill with medications. Okay. We talk about neurocog. We're talking about delirium and dementia. What is the difference?
Delirium is an acute onset and dementia is permanent.
Mhm. Delirium is always acute onset, is typically after secondary to an infection like pneumonia or UTI. That's where I got a lot of my geriatric psychiatric patients when I first got out of school is, oh, well, mom was fine, and then all of a sudden she is confused and aggressive. Um, and we get a urine sample, and bam, she has a UTI. So that's where delirium's coming from. So again, like you said, acute onset is delirium, and it's typically secondary to an infection like pneumonia or UTI, even after surgeries. Dementia, again, permanent, ongoing, progressively getting worse. Dementia is an umbrella term. Underneath that umbrella of dementia is the most common one is Alzheimer's. Dementia with Lewy bodies, HIV induced, TBI induced, all the things. But remember, dementia is an umbrella term um, that houses a lot of different actual mental illnesses in like underneath it. Again, signs and symptoms could be, again, acute confusion. And again, if it's dementia, it would be progressively getting worse, things like that. Inability to do certain things. But it's usually that confusion, maybe aggressiveness, irritability, just not themselves. What do we think about autonomy in neurocognitive disorders with dementia? So we know that it's progressive. We know that it's likely to get worse. How bad? We don't know. We can treat it, but we can't cure it, right? So talk about autonomy with dementia. Kind of said it with older adults too. What do we want them to be able to do? Any individual who has dementia, what do we want them to be able to do?
We want them to keep doing as much as they can, as long as they can for
Yes,
themselves.
good job. Doing all that they can by themselves for as long as they can safely,
Mm.
right? If they need a little bit of help, that's fine too. Let's do that. But if they don't, if they can set up all their things to take their shower or whatever, let them do that. If they need just a little bit of help, just kindly say that and ask them if they need help, those kinds of things. But again, like Angela said, we want to have them be the ability to do all the things that they need to do by themselves for as long as they can safely by themselves. Good job. Um, the A's. What's aphasia?
Difficulty communicating or expressing words.
Yes, aphasia, loss of words. Think strokes. Um, that aphasia occurs. Some people get aphasia from being super, super anxious. And again, these are just like terms like aphasia, like at the top. So again, aphasia is like loss of language, loss of the ability to like communicate verbally. Um, I've experienced it before. It was in relation to I think like food and fluid intake. I was just like really dehydrated and things like that. And I think I got over the flu or something, and I literally lost the ability to like communicate. It sounds like I was like slurring my words, like all the things. And you get to the ER and they're like, "You going on a bender?" No, like I didn't drink alcohol. Like I don't know how this happened. But again, sometimes the aphasia can occur from anxiety, and then they lose the ability to find the words. Sometimes it's like complete loss of language where I can't even speak, those kinds of things. Scary situation. Apraxia, that's loss of purposeful movement. Um, Loss of purposeful movement. Agnosia, that is the sensory ability to recognize objects. So they might think that an apple is actually a ball that's sitting on the desk or something like that. Okay. Then agraphia. Graphia means writing, or aka reading as well is paired with that as well. So graphia is again inability or issues with communication for reading and writing. Make sense? But the main ones I want you to focus on are again the A's. There's one more of them. Right? I don't know. Um, the one that I want you to think about the most when we're thinking about older adults and neurocognitive disorders um, is aphasia, that loss of ability to communicate. Because what can occur if you can't communicate to your nurse your needs? What typically happens? Or somebody's not listening to you because you can't talk. What happens?
You don't get the care that you receive the care that you need,
Absolutely.
possibly. Yeah.
You want to say all the things like I want to talk so bad, but if I open up my mouth, it's going to sound like slurred words. They're going to think like I've drank like I don't even know like a gallon of alcohol. Like I've not. Like it was really scary situation. Like literally cannot speak out of nowhere. That's usually how it comes. So again, the aphasia, the praxinosia, and agraphia, the A's, they typically occur with dementia because it's again long term, and these things occur over time. But also, they don't always have to. Like again, aphasia. Am I having a neurocognitive disorder? I might. I don't think I do. Got other things. No, but again, it can be outside of dementia as well. Even individuals with delirium can lose the ability to speak. Is it going to be long term? No, acute, right? So again, good job. Autonomy, the difference between each delirium and dementia, signs and symptoms you'll see, important, imperative, and you guys already said it here. Good job. Death and dying. I'm not going to spend too much time on that. Why is that font different? That's weird. Sorry about that. Dr. Kubler-Ross came up with stages of grief, right? Grieving is the outward or emotional, so the outward expression of internal, symptoms, thought processes, things like that. When a there are different types of grief, and society basically tells us what's good grief and bad grief, if that makes sense. Like some people will believe that, again, disenfranchised grief right here is an example. If you've taken care of a patient, let's say you work long-term care setting, and this individual, you're nursing critical thinking skills are probably close to, maybe end of life, things like that. They've been your patient for, let's say, a year, right? The long-term care. And they pass away. Society tells us that we as nurses aren't supposed to grieve that loss of that patient. But society doesn't realize the whole purpose of any kind of nursing is therapeutic communication and empathy, right? The art of nursing, compassion, empathy, all the things. So again, society tells us, quote unquote, what is appropriate grieving or not. So again, if someone is cheating on their spouse and the person who is the third person outside the relationship, something happens to them. Can the person that cheated cry? They probably shouldn't grieve, right? They can, obviously, but does society tell us that that's okay? Mm-mm. So it's like disenfranchised grief too. Even loss of an animal, like per Kubler-Ross, per our book, per everything that we've gone over in class and befores and voiceovers, disenfranchised grief. We are not to like grieve patients, dogs, anything, or animals in general, things like that. Makes sense? I think that's chapter 30. But don't spend too much time there. Just know, denial. We know that individuals, the first thing, again, trigger warning. I have literally in the past 3 weeks, I have lost 3 people. One of which I didn't know, 2 of which are obviously my aunt and a close friend. Have I grieved the loss of my aunt? I've tried. I'm okay. And my sweet students were okay. So they're so kind. But this friend who, we don't live in the same city anymore. We are close, but it's not like the everyday text or, call. I felt silly grieving that loss because we hadn't seen each other in years. But does that the length of time between being around that person matter? No, right? Because I can reminisce, think about all the times that we had together, like in high school and college, even before they left, and think about that. And so again, the first thing I said when mom like called me and said like, "Hey, like, are you sitting down?" Don't ask me that question. Like, don't. Am I sitting down? Like, because I'm gonna pass off. You tell me something bad news. That's my mom's like go-to saying when she's about to tell you something terrible. So the first thing somebody really says is, "Oh no, that can't be true." Like that's not true. That's straight denial, and that's our immediate thought process. The brain immediately goes to denial. Okay, is denial okay? Yes. How long that thought process goes on is what's most important. So I can be in denial about, like my aunt's still here, right? There's a gnat. Sorry, I don't know what's coming from. That my aunt's not here. This is like a week ago at this point, I think. Am I good? Yes. Am I in denial? No. I've moved on, right? So there again, there are stages. But again, most importantly, the stage is quote unquote just like defense mechanisms. That's what they are, good or bad based on the length of time used. So again, if something happened like a year ago and I'm still in denial, that's not healthy and I should have got help a long time ago. Questions about that? And again, remember this because as a nurse, like I find it very, and you too, like you guys will do this. You'll have patients, doesn't matter mental health or whatever. You'll have patients that will probably, unfortunately, leave the earth while they're around you in the care, or them. And so remember this disenfranchised grief for sure. Again, society tells us what is appropriate to grieve. Remember, it's just like sexual disorders. Society tells us what's okay, things like that. Okay, good job. All right, tell me about what is the ethical, the study guide thing is theirs too. Do we just, as nurses, go to school, sit for the NCLEX, pass it, get a job, start working, and just like do whatever we want to do?
No.
We have taken an oath to conduct ourselves in a manner that is professional, ethical, empathetic, all the things. The Nurses Code of Conduct is called the Code with interpretive statements. I have it on my bookshelf. Tells us how we are supposed to act as nurses, what kind of conduct we are to do as nurses, what we can and can't do. I encourage you to buy the book. It's cheap, but it does again tell us what we are supposed to do as nurses. We're held accountable to that code. So even when you think about literal, what it like if you're doing something and you know like it's not the right way to do it, but it's a shortcut, like do you automatically think of, oh no, like the code of it? No, you don't. But you should probably keep that in mind for sure. And I hope you're not, that's a poor example, but ethical conduct, the code, interpretive statements, the code, ethical professional conduct. Prudent. What does prudent mean? I said it earlier. I was like, the prudent nurse should. You guys will become prudent nurses. Prudent nurse is a nurse that knows their scope of practice, conducts himself in all the way the code says, and knows their specialty. It doesn't have to be a specialty. They know their job, they know their things, they have become basically experts at what they do. Does it mean they know everything? No. They've become like really cognizant and aware and up to date with all things that they're interested in, like again, the unit they're working on, things like that. That is a prudent nurse. We obviously, again, conduct ourselves in ethical, professional manners. Again, think about patients' rights, think about our rights, all the things. But the prudent nurse conducts themselves in a professional and ethical way, and that's determined by the interpretive statements for the code, the nursing code. Should I grab it off this shelf? I think it's right there. Does that make sense?
Mhm.
We have rules, boundaries, all the things. What's ethical and what's not. So I don't think this is going to be an issue with any of the students who will watch this video as well. But just keying in on there is an ethical and professional code, and it's interpretive statements for nursing. Make sense? Okay. That was it.